Hi, good evening, everybody. My name is Emma Annis Hansley, and I'm going to talk about cancer health disparities in ovarian cancer in the United States. So let's just start off by talking about ovarian cancer. It's the fifth leading cause of cancer deaths for women in the United States, and it's pretty common. The lifetime risk of getting ovarian cancer for women is around 1 in 78, so it is fairly evident in the population. Age is a big factor for ovarian cancer, and around half of the women diagnosed are over the age of 63. And it's important to note that the prevalence of this cancer is higher in Caucasian women than African American women. And we have to remember that for later on. So ovarian cancer, it can start in either of the ovaries, and more recently it's been discovered that it can start as well in the far end of the fallopian tube. So this end, and then in either of the ovaries. The ovaries are the reproductive glands that home unfertilized eggs in the woman's body. And they are made up of 3 different cell types, and they also are the main source of hormones, estrogen and progesterone. So they're made up of 3 different cells, and then each of the different cell types that make up the ovary can result in a different type of tumor. So epithelial tumors stem from the outermost surface cells of the ovary, and actually the majority of ovarian cancers are from the epithelial cells, with 85 to 90%. And they also have the highest malignancy, unfortunately. Then we have the germ cells, and that makes up less than 2% of tumors. And then we have stromal cells, and those make up around 1% of tumors. The germ cells stem from the cells that produce eggs, and then the stromal cells stem from the structural tissue that hold ovaries together, and they also produce estrogen and progesterone. Some risk factors for ovarian cancer. They're pretty much in line with most other cancers that we've learned about. Age, obesity, diet, smoking are all major risk factors for all types of cancers, as well as familial history of cancer. What's unique to ovarian cancer is that a woman who has had her first full-term pregnancy over the age of 35 or has never carried a pregnancy to term, so has never given birth to a baby, they have an increased risk of ovarian cancer. Also, post-menopausal hormone therapy, so if a woman has gone through menopause and she's starting hormone therapy to maintain levels of estrogen in her body, she can be at a higher risk. Personal history of breast cancer, and then along those lines is having the mutations in the BRCA1 and 2 genes that also increase the risk of breast cancer. That's called hereditary breast and ovarian cancer syndrome. So the signs and symptoms of ovarian cancer. I put this picture here because the signs and symptoms of ovarian cancer are very discrete, or they can be aligned with many other illnesses as pictured here. So bloating, pelvic and abdominal pain, anorexia, weight loss, not wanting to eat, feeling satiated very early, GI upset, urinary urgency, frequency, menstruation changes, and then dyspareunia, which is pain during intercourse. A lot of those symptoms can be found in other illnesses like endometriosis or appendicitis, pelvic inflammatory disease. So it's very hard to diagnose ovarian cancer based on signs and symptoms because a lot of times they can be misinterpreted or misdiagnosed with a more common illness. And then another reason why ovarian cancer is so hard to identify is because only 20% of ovarian cancers are found at an early stage. So there is no screening test for ovarian cancer as there are for other cancers. They can do a transvaginal ultrasound, and that can detect masses, but ovaries can have cysts or masses for many different reasons. So, and the transvaginal ultrasound can't detect cancer, so it can't detect the cancerous cells, but it can detect a mass. And then from there, they can choose to biopsy. There's also the CA125 blood test, and this blood test measures the amount of CA125 protein in the blood. It happens that women who are diagnosed with ovarian cancer oftentimes have high levels of this protein, but women that have endometriosis or pelvic inflammatory disease can also have high levels of CA125. So it's really not useful as a screening tool because the other conditions, again, they are common, and the ovarian cancer can go undetected pretty easily. It's staged with the TNM method because they are tumors. And this shows, using the SEER stage method, the 5-year survival rate based on if the cancer is found when it's localized, regional, or distant, and then the all SEER stages combined. Really, you can really see how, as the cancer metastasizes, how high the death rate goes, or how low the death rate, the survival rate goes, and the death rate increases. And putting that on top of the fact that it's so hard to detect ovarian cancer that a lot of women that are diagnosed, it already may be metastasized, and their survival rate is not good. So it's so important that women are screened early and getting the care that they need to stay on top of their health. Treatment, so in early stages, they can surgically remove the ovary or the tumor. Hysterectomy, that is the removal of the uterus. The bilateral salpingo oophorectomy, and that removes the fallopian tubes and the ovaries and those reproductive structures. They can do chemo. The most common drugs are carboplatin and paclitaxel. And then later stages, when it's more difficult to treat, the tumor can be debulked, and that is when they remove much more of the female reproductive system, uterus, fallopian tubes, ovaries, omentum, which is the fatty tissues of the upper abdomen, and then sometimes the cancer, it can spread to intestines, small or large, so their intestines may need to be resected as well. After surgical removal of the tumor, they can utilize chemo. Targeted therapy includes Avastin, and then palliative care if the tumor or the cancer has metastasized past the point of being able to be treated. So in regards to health disparities, I have this quote here: disparities in health and healthcare are most likely to occur among women who are members of racial and ethnic minority groups. And then I read a study that was a population-based report, and it looked at over 172,000 cancer cases between two periods of time, so 2001 to 2003, and then 2004 to 2009, so two separate cohorts. 85% of the women were diagnosed were white, which I noted earlier that ovarian cancer has higher incidence in white women, and over 50% of the cases they were diagnosed at a distant stage, so that shows how difficult it is to detect at an early stage, and that unfortunately a pretty high percentage of ovarian cancers are diagnosed when it may be too late for treatment. Given that it's more prevalent in white women, Black women had at least a 10% decrease in their 5-year survival rate for both periods. So for both 2001 to 2003 and 2004 to 2009, they had a 10% decrease in the 5-year survival rate. So population-based cancer survival, it can reflect the average survival for all patients regardless of age, sex, race, socioeconomic status, access to care. It does not only count those that are hospitalized, so these numbers are often underreported, and this study shows as an excellent indicator of the overall effectiveness of the healthcare system on cancer detection and treatment. So we can really see those vulnerable groups, and it helps practitioners to identify the highest risk populations for educational intervention and environmental or health system changes to implement. So this study shows that there is an enormous disparity in Black women as opposed to white women. They had a lower survival rate compared to white women for each stage of cancer. So we have localized, regional, distant, and then unknown. And for each stage, they had at least a 10% decrease in the chance that they're going to survive 5 years after being diagnosed. Now, this shows a true and widespread racial disparity in ovarian cancer survival because there's little to no evidence that Black women would be more impacted by ovarian cancer other than they may not have access to the same resources, or maybe it's not being detected early enough in their cases. So it's detected later because they don't have access to frequent and consistent care. So why do these disparities exist? Number one is patient. So patients' understanding of the medical information that's presented to them when they have an appointment with their doctor or anything that they look up online. It can be influenced by cultural and language differences. That's just, unfortunately, it is a huge barrier to some individuals who are living in America and have this Americanized Western medicine when traditionally they use a much different type of medicine. Women with lower levels of education and health literacy, they're less likely to advocate for quality of care because they just don't have the knowledge of what they should be getting. And then general mistrust in the healthcare system due to past abuse on African American people, such as forcing women of color to be sterilized not many decades ago, and the Tuskegee syphilis study. Then we have societal influences. So as I was saying before, that ovarian cancer needs to be detected early on for treatment to be effective, but that means that they need to have frequent checkups, established connection with their OBGYN or primary care doctor. And then we have institutionalized racism, that providers may treat African American women differently, or they may just have a disconnect. And then lasting effects of segregation. Certain areas in the country, certain neighborhoods, certain cities, they may have less resources in general. So I put food deserts as well, less access to food, which then attributes to the risk of obesity and unhealthy diet, and then that's a main risk factor for cancer. And then living in areas where healthcare isn't as accessible. Maybe healthcare workers don't want to work in that area because they won't be paid as much as if they work in a big city. Healthcare. So based on statistics from 2013 is that almost 60% of uninsured African Americans who would otherwise qualify for Medicaid expansions lived in states with no plan to enact the expansion, so that directly puts them at lower access to care and a huge disadvantage. We have undocumented immigrants. They're unable to receive good insurance or any insurance in most states, and then where they can get insurance is often very limited. And the American Cancer Society study that I researched showed that Black women consistently did not receive guidelines-based treatment for ovarian cancer. And that may be in part due to the difficulty in accessing good or quality hospitals with physicians that have knowledge on cancer, specialty oncologists. And then we have providers, so implicit bias. We all have it, regardless of who or what you do. It's important that people all recognize their implicit bias. And then the percent of medical doctors who are minorities. So we only have 9% of medical doctors that are from minority populations, while the US is comprised of over 30% of minority populations. So our doctors don't reflect our population. That's an issue. What are we doing to address these disparities? And definitely not enough. We'll get into that. So what needs to happen to address healthcare disparities? And then what can we do as healthcare workers? We can use quality improvement projects, such as the study that I looked at that noticed the disparity. We need to see where the issue is and then look at where we can increase quality to a population that needs it. Educate staff on community resources, so educating staff on how to tell patients, this is care navigation, or I can help you sign up for the ride. I can help refer you to this clinic that works especially with women like you. And then work alongside public health agencies, and that can help just to spread awareness of what's going on in certain populations, to know if there's a flu outbreak in a certain area, or there's exposure to some sort of toxic chemical, and then know where areas where health education isn't as strong. Then workshops for providers to identify their own implicit bias. As I said before, we all have implicit bias, unconscious bias. Some workplaces will host workshops where they have a speaker who can help speak about what implicit bias is, because a lot of people don't know what it is. And then in the workshop, employees can help to identify where they have implicit bias and then notice that change and implement it in their workflow.